This brings us on to the second case that will be presented and will be introduced by Anna.
Great. Could I ask colleagues who are leaving to do it very quietly, because remember, we're filming you and you'll be seen on the film and the audience will find it difficult to watch. So our second case is entitled Hypertensive Encephalopathy and Renal Failure in a Young Man. So we're moving to something really different, and it will be presented by Drs. Hunter and Dawn from UK, also from Edinburgh. Please.
Thank you very much. We're presenting a case from the east of Scotland as opposed to the west of Scotland, from Edinburgh, and hopefully it'll be as interesting as the last case was. We're going to do things slightly differently, however. We're going to show you a case that was largely managed within the nephrology service, so the management of hypertension may well differ to what is seen elsewhere within specialist hypertension services. We're also going to invite the audience and the chairs to take part in the investigation and management of this patient, to stimulate discussion and to display how difficult it was along the way, that a number of options were available to us. So on that basis, I'm going to pass over to my colleague, Robert Hunter, who will start off with the case.
Thank you. So our patient, a 35-year-old man, was a hospital doctor working in Scotland. Although when he became unwell, he was attending a medical conference in the north of England. And what happened when he became unwell was that he was in the habit of phoning home once a day to his wife, and one evening he didn't call home. And I'm sure those of you who are in the habit of attending medical conferences might not be too surprised by that. So initially his wife thought perhaps he was at a particularly engaging evening session, or maybe he was discussing science or medicine at the bar. But as the evening wore on, she became increasingly concerned that he hadn't called home. So much so that she called his colleagues, they went round to his hotel room, they couldn't gain entry to his hotel room, and eventually called the police, who broke down the door. And inside they found that he was very confused, so confused in fact that he couldn't remember his own name. It transpired that this presentation was preceded by 7 weeks of what he thought were migraines and some blurred vision. He had nothing formal in his past medical history, but later recalls that some 15 years previously, an attempt had been made to do an arthroscopy, and that had to be cancelled because his blood pressure was high. He was under the impression that his blood pressure had normalized over subsequent months, but this was never recorded, so that may or may not be true. He had nothing of note in his family history, he was on no regular medication, he was a non-smoker and took only occasional alcohol, even when he was at medical conferences. So he was a large man weighing 108 kilos. His blood pressure in the accident and emergency department, which is where he was taken, was 250 over 138 millimeters of mercury. He had bilateral posterior shoulder dislocations and had bitten his tongue extensively. So the presumption was that he had been fitting for quite some time whilst he was in his hotel room. And indeed he went on to have a generalized seizure in the accident emergency department. He had to be anesthetized, sedated and ventilated for seizure control, and after that point it was possible to perform fundoscopy, which revealed bilateral flame hemorrhages and papilledema. He had quite a stormy course on the intensive care unit, so he was, there was an attempt made to extubate him on the second day, but he had further seizures following this and was re-sedated. His blood pressure was initially controlled with intravenous labetalol, and when he was ultimately extubated for the second time, he was immobile because of his shoulder dislocations, cortically blind, and perhaps fortunately had retrograde amnesia for the entire event. His initial investigations revealed fairly significant renal impairment, so for those of you from the States, we've put American measurements at the top and for Europeans down at the bottom, but either way this demonstrates pretty marked renal impairment. Electrolytes were normal. He had an active urine sediment. A full blood count was normal and there was no evidence of hemolysis on blood film. C-reactive protein was elevated and serum albumin was low, compatible with an acute inflammatory event. been?
So we're going to just pause there to ask if you'd like any further information, but in particular, what further investigations you would want at this stage were you looking after this gentleman?
It's very, very, very quiet, very quiet.
Anybody interested in doing any investigations in this gentleman? Feel free to shout out.
I think whilst they coming to the microphones, we need to see the kidneys.
Okay, so you'd like to see the kidneys. So you'd like an ultrasound scan? Yes. Okay, an ultrasound.
Ultrasound would be good.
Okay, an ultrasound scan of the kidneys. Anything?
Head CT.
Okay, head CT. Anything else? Sorry? So his LDH was normal, so he had full hemolysis screen, he had serial blood films, there was no evidence of hemolysis. Anything else? So we've got a brain CT and an ultrasound scan of the kidneys. The urine, what would you, so we know the urine was, would you like some more quantification in the urine or analysis of the urine? Proteinuria, okay, fantastic. Yep.
Did we examine the fundus examination? I'm here.
Sorry.
Yeah, fundus examination and listening to the renal artery. Is any bruit in the renal artery, in the carotid, in the femoral? Because this is any one young patient with hypertension, we have always to listen to the renal artery and look for the fundus.
Okay, thank you for all those.
We would like to have you at the microphone because it might not film very well. Yeah.
So we've had a number of investigations there. Just to reply to the gentleman before that, we did do the fundoscopy and there were flame hemorrhages and papilledema evident. So I'm going to pass you back over to my colleague who's going to go through...
Could we allow Professor Stassen to say something?
I think in this patient I would do brain imaging and I would do puncture of cerebrovascular fluid, the cerebral fluid.
Fantastic.
To see whether there is any blood in it.
Okay.
The simpler echo ultrasound of kidneys.
Brilliant.
Okay. Schistocytes?
Schistocytes. So the blood film showed no significant abnormality on it.
Urine toxicology. I had a patient like this recently who happened to have misused cocaine.
Yes, okay.
And while we're collecting urine, metanephrines or some sort of catecholamine.
Fantastic. So a lot of investigations there. So I'm going to pass you back over to Rob now.
Okay, so let's see what happened.
So thank you. So I think we can answer all of your questions with... we didn't do this actually because he was still at the centre in the north of England, but I can show you what all of these investigations revealed. So this is his electrocardiogram, which doesn't show left ventricular hypertrophy by voltage criteria, but he did have concentric left ventricular hypertrophy on echocardiogram. He had initially a CT brain and then an MRI of his brain, and we show the MRI here because it is more informative. But you can see on this T2 weighted image, there is hyperintense, in fact, we've got a pointer. So there is white matter, high signal here in the occipital lobes bilaterally and the parietal lobes, but clearly more evident on the right. In the clinical context, we felt this was compatible with posterior reversible encephalopathy syndrome, PRES, which is a syndrome that can be caused by accelerated hypertension, but can also be caused by autoimmune conditions. The neuroradiologist offered a differential diagnosis based on the imaging, which also included stroke and demyelinating disease. His renal ultrasound showed two unusually large kidneys measuring 18 and 16 centimetres. And in a chap of his size, I guess a normal bipolar length would be closer to 12 centimetres. And the kidneys had multiple cysts in them on both sides, and we've just shown the largest cyst here in the right kidney, which measured 6 centimetres. He had these extra blood tests, so his random plasma cortisol was significantly elevated, perhaps unsurprisingly, with a elevated 24-hour urinary cortisol excretion. Plasma and urine catecholamines were within the reference range. He also had a complement screen, which was normal, an autoantibody screen, including looking for PR3 and MPO anchor and anti-GBM. These were negative. He did have a lumbar puncture, and the CSF analysis was normal. And in light of his neuroimaging, we obtained a thrombophilia screen which shows a mutation in the prothrombin gene which confers an increased risk of venous thrombosis and also of premature atherosclerosis. But I will remind you that this patient and his family have no history of venous thrombosis. He did have proteinuria, and these other investigations show an elevated serum creatine kinase compatible with his seizures. Cholesterol was 3.9, and his parathyroid hormone was above the reference range, in keeping with an element of chronic kidney disease. I'll hand you back to Bean.
So, as I said, this gentleman was looked after within the nephrology service. So based on these investigations, we felt that this gentleman probably had a diagnosis of polycystic kidney disease, so autosomal dominant polycystic kidney disease. But I'd like to ask the audience now and the chairs, what do you feel about that? Is there any further information you would like to be compatible with that diagnosis, or do you disagree with us?
I do not get that sense. Why is the proteinuria there? There's too much proteinuria for polycystic kidney disease. This could be acquired cystic disease from chronic CKD. Why would you obtain cortisol and metanephrines at the time of stress?
Okay.
What's the value of that?
Sure. So in answer to your first question about the proteinuria, so I agree with you to a degree. In polycystic kidney disease, however, you can get proteinuria up to, it's about 0.5 gram roughly, and you can get that. It's a tubular disease, so you get tubular proteinuria, which up to about 1 gram is normal. However, what I would say is that in the setting of high blood pressure, that in itself will give, because of the transmission of pressure, will give you a degree of proteinuria, which would not be unusual. With regards to your second question about the cortisol, I absolutely agree with you, but what I will remind you of is that this gentleman was looked after by anaesthetists in the intensive care unit, and I suspect it was on the list of things to do when somebody presents in this fashion. But I agree with you that in the setting of stress, those readings would be compatible with stress.
Do we know anything more about the family history? Because adult polycystic kidney disease with this type of advanced kidney disease without any family history would be very unusual.
Absolutely.
Autosomal dominant is autosomal dominant.
Autosomal dominant is autosomal dominant.
Tell us.
And as Anna says, that implies that 50% of the family members should be affected.
Yeah.
So we'll come on to the family history in a bit. Anything else anybody else would like?
In this microphone.
Because the result of biochemistry, when he came, his potassium is 3.6 around, and usually somebody have seizure, was fit for some time. The CPK usually high, and also maybe the creatinine high, part of it due to high CPK, but potassium usually high. And with low potassium, this is maybe indicate that the patient have really like a severe hypertension, or what we called it before, malignant hypertension. That's why the potassium is low. Now, just because this is possibility, polycystic kidney disease, will not look to the son and daughter, but we should look at least any one of his family have hypertension, brother or sister. I think these people should be looked carefully, because this is the case. We need to diagnose them and also to follow them up.
Okay, so I would agree with you about looking for the family history, as mentioned by one of the chairs, so we will talk about that in a minute. With regards to potassium and seizures, I agree with you that many things will be elevated in the biochemical screen around the time of the seizures, such as lactic acid, potassium, CK. However, what I will remind you of in the story is that this gentleman was found at some point after he'd been seizing, so we don't know what the time course difference was when he was seizing to when he was found. And whilst I agree with you that the potassium may well have been, and probably was elevated at the time of seizing, maybe the time course was sufficient that he cleared the serum potassium. And also I'll remind you that the ECG that we had from the A&E department was normal and showed no evidence of any significant kalemia. So I'm going to pass you back over to my colleague now.
Okay. So we hear now about family history.
Yes.
Okay.
So further imaging. Actually, nobody asked for further imaging, but because it gives you a prettier picture, we proceeded to obtain a CT scan and then an MRI scan. So this showed grossly enlarged kidneys and multiple cysts bilaterally. It also showed a single liver cyst measuring 2.5 centimetres, but that's not out of keeping for what you might expect in a gentleman of this age. That was the predominant reason for requesting the further imaging, to look for liver cysts. His family history did not go along with polycystic kidney disease in that his father and his sister were both screened in light of this by ultrasound, and neither had renal cysts. And they're both of an age where that effectively excludes a diagnosis of autosomal dominant polycystic kidney disease. He had no other siblings. His mother died in her 30s of a presumably unrelated cause, but it's not impossible that she had cystic renal disease that was undiagnosed. We think his diagnosis is polycystic kidney disease, autosomal dominant polycystic kidney disease, which is one of the commonest monogenic disorders in humans and enjoys a prevalence of between 1 in 400 and 1 in 1,000. It's caused by mutations in one of two genes, ADPKD1 or ADPKD2, which encode polycystins 1 and 2 respectively. These are inherited, as you correctly state, in an autosomal dominant fashion. But about 25% of patients, when they are diagnosed, have no prior family history. If you screen family members, you detect a significant amount of clinically silent disease, so the true rate of sporadic mutation is thought to be around 5%. Liver cysts support a diagnosis, but are absent in 20% of patients and are more common in women. And we agree with the point made that there is a differential diagnosis of cystic renal disease, particularly in the absence of a family history, but we felt that his presentation wasn't in keeping with any of the differentials listed here. I believe the point was made that acquired cystic disease is a possibility, but the cysts were particularly numerous and you will see on subsequent slides, were out of keeping with his degree of renal dysfunction.
I'm just going to add to that to have something like, so there are probably too many cysts, both throughout the cortex and medulla, for it to be simple cystic disease. Acquired cystic disease would be uncommon to have this many cysts at this age. The number of cysts do increase with age, but at the age of 30, you probably wouldn't see this many bilateral cysts, so it would be unusual. And as Rob says, there was no other features of tuberous sclerosis, which I'm sure you're all aware of, and there was nothing to suggest that hereditary disease in terms of interstitial nephritis.
So we'll move on to discuss his...
There is a discussant.
Sorry.
Let people talk.
I'm not sure why this patient have this thrombosis. People who have high blood pressure, they usually maybe a tendency for bleeding, intracranial hemorrhage, but this man, he have thrombosis. I understand it's thrombosis. And in the MRI does not show any lacunar infarction before. So blood pressure produce thrombosis. It can produce thrombosis, but unusually in one attack, he have this. So is there some predisposed patient for thrombosis, something coagulation factor problem or lupus anticoagulant, but I will not expect that he will develop thrombosis in this situation. He should be bleeding more than thrombosis.
So we didn't demonstrate in him that he had a thrombosis. His neuroimaging we felt was compatible with PRES, posterior reversible encephalopathy syndrome. Because the differential diagnosis based on the neuroimaging would include thrombosis, we did a thrombophilia screen and unearthed that he has a thrombotic tendency. But I should say he went on to have serial imaging and the appearances in the brain resolved entirely in keeping with PRES. So we don't think he had thrombosis. And you're right, it doesn't really fit.
Okay, another comment, please. Could you identify yourself?
Certainly. Bertram van der Born, Amsterdam, the Netherlands. I just wondering, you made a diagnosis of polycystic kidney disease and you had some nice MRI imaging. Was there any evidence that one of these cysts was compressing the renal artery?
So that's a very good question, and on that imaging, no, there wasn't.
Thanks.
Okay, so you can continue.
Thank you. So we now discuss his progress over the first couple of weeks, and you can see that his serum creatinine, which at presentation was around 350 micromolar, fell to a nadir of 1.64 mg per deciliter, which is around 150 micromolar over the first week. And his blood pressure improved also. So it's at this point here that he was transferred to our centre from his presenting centre. Initially, his blood pressure was treated with intravenous labetalol and enteral amlodipine administered via a nasogastric tube, but he was transitioned to oral agents over the first 2 or 3 days, so that when he arrived in our centre, he was on doxazosine, amlodipine, and metoprolol, all at maximum therapeutic doses. His blood pressure had fallen, but was still around 160 over 110 millimetres of mercury. I'll hand over to Bean.
Okay, so the next question was, well, what do we do now? He came to us and he remained hypertensive. So to remind you, his blood pressure was around 160 systolic with a diastolic greater than 100. His renal function had improved significantly, but was still significantly impaired with a creatinine of around 150. Now, just for some more information, because to us, creatinines vary between patients depending on age, sex, muscle mass, this creatinine of 150 gave an estimated glomerular filtration rate of around 35 to 40 mils per minute. However, what I will tell you is that when we did a 24-hour urine collection looking for an estimated creatinine clearance, that GFR probably was closer to around 80 mils per minute. So the estimated GFR in the laboratory measurement was underrepresenting his actual GFR. So his renal function was reasonably good. And his current medications in terms of blood pressure control are listed at the bottom. So we've given you some options. You don't have to choose these. So we were tossing up the options of, well, should we start him on an ACE inhibitor? As you know, nephrologists are very keen on ACE inhibitors. And in terms of blood pressure, to us, probably lower is better, but we don't quite know. So we had the option of an ACE inhibitor or an angiotensin receptor blocker. We could have started diuretic. There's the option of an alternative antihypertensive agent, and if you go for that, I'd be interested in which one you would go for. Or you could do nothing here. Might I ask for suggestions from the...
Okay, there are suggestions on the right. Please go to the microphone.
Yes, Jamal Wakil from Saudi Arabia. Now, we know that ACE inhibitor is very good for polycystic kidney disease because it slows the growing of the kidney, and also the same, many of mechanism is due to renal angiotensin, since the hypertension is due to renal angiotensin. I think this is should be used in treatment of patients with polycystic kidney disease. The only thing this patient have acute kidney injury. With acute kidney injury, we didn't like to use ACE inhibitor because if you use it, maybe deteriorate kidney. So the doxazosine, I think it's not a good drug, and it can be replaced with other drug. And when it gets stable, I put him in ACE inhibitor.
Okay, thank you for that. Can I ask, are you a nephrologist? No. Yeah. Are you a nephrologist? Okay, that's fine.
Okay, we have another comment.
I think you must absolutely add the ACE inhibitor or angiotensin receptor blocker. If you have still albuminuria, that I think that he will have.
Okay.
First, in the urine, had 3.
Did he have sequential urine calculations of protein?
He had.
So yes, he did, and all of the measurements for proteinuria were below 1 gram per day. So all the ratios, whether you call it an albumin-creatinine ratio or total protein to creatinine ratio, were all less than 1 gram a day. I do take your point about an ACE inhibitor conferring greater protection when there's proteinuria. The only thing I would say about that is that the current data supports that when the proteinuria is greater than 1 gram a day. So, for example, the UK guidelines, I do agree with you. I would probably have somebody on an ACE inhibitor for proteinuria. However, the guidelines in the UK certainly suggest that the target proteinuria is less than 1 gram per day.
Okay, so the opinion here appears to be ACE inhibitor or ARB.
Could I just ask you, what is his cerebral status at this point?
Yes. So, Rob, do you want to answer or shall I? Okay. So, he was very frustrated at this point. So he was in hospital for about 3 or 4 weeks, and his cortical blindness improved gradually, and he was mobile in the upper half of his body because of the bilateral shoulder dislocations. So his cerebral function improved over days in terms of he was cognizant, able to communicate. But, I mean, to be fair, whilst we never assessed it formally, he was probably depressed, which was appropriate for the clinical setting. But he was able to discuss appropriately discussion making. So he was engaged in all discussions, especially given that he was a doctor, his wife was a doctor, his father was very important in the medical school. So lots of people were involved in these discussions.
Thank you.
Okay. So tell us what you... sorry, there is one more comment before you tell us what you did.
So, to follow up on the AKI.
Yes.
you must have thought that this was not an AKI by the time you measured the 24-hour collection, because it has been in steady state. So if you're comfortable with the GFR of 80, that he had reached a steady state now,
yes,
then you would go with an ACE inhibitor, maybe captopril, that we don't usually use for a very short acting in this situation to test how he would react. But if it was not in steady state, then I agree with Dr. Al-Wakil that we can wait.
So I would agree with you that the GFR is good. However, what I would say is that I still think he probably has acute kidney injury, because a creatinine of 150, I think for most people would be impaired. What I cannot tell you is what his historic creatinine was. So I don't know whether this was baseline renal function, as it might have been because his PTH was slightly elevated, or whether this was acute and we didn't know what his baseline was yet. And you would think that we wouldn't introduce the ACE inhibitor because, for the reasons that you've highlighted, that this could be recovering acute kidney injury.
Okay.
So.
Don't keep us in suspense any longer. Tell us what happened.
So what we did, rightly or wrongly, was start an ACE inhibitor. So we chose ramipril at a dose of 1.25 milligrams a day, and because we were feeling brave, we titrated that up to 10 milligrams within about 48 hours. And fairly predictably, his creatinine rose again in response to this. I'm sure because we did introduce it prematurely in the context of an acute kidney injury. He was discharged from hospital at this point here, and we crossed our fingers and hoped that when we saw him in clinic a week later things would have improved, but his creatinine had risen still further. He's got a good blood pressure though, but this is a rise to about 250 micromoles, which is about 70% from baseline, and the current guidelines would suggest that if you have a rise in creatinine of more than of more than 30%, that you should consider withdrawing the ACE inhibitor again. I wonder if, in the interest of time, actually, I'll tell you what we did here, because it's not. This bit isn't rocket science. So, in light of his deteriorating renal function, we elected to stop the ramipril, and what happened thereafter is that his creatinine fell back to its previous nadir value, and it was actually during this phase here that we obtained the 24-hour creatinine clearance when he clearly was in steady state. So at this point here, his EGFR is around 40 and his creatinine clearance is around 80 mils per minute. But we felt this was entirely in keeping with resolving acute tubular injury, which we had exacerbated with ACE inhibition. He was now at home, so was getting ambulatory or home blood pressure readings, and his typical readings were 150 over 100 with no nocturnal dip. So we then faced the same decision, really, but 2 months down the line, about what is the optimal antihypertensive therapy in this patient, and has already been alluded to. There is a bit of an evidence base behind this, specifically in polycystic kidney disease. So we thought this was a good point to review the pathogenesis of hypertension in polycystic kidney disease and the evidence guiding antihypertensive strategy. So I will do that over the next few slides, and then would be interested in your thoughts on how to interpret the literature, because I don't think it's straightforward. So the first thing to say is that hypertension is, of course, very common in chronic kidney disease. You all know that, and population estimates in large-scale studies estimate that it enjoys a prevalence of around 85% in CKD compared to about 30% in a matched general population. It's similarly common in polycystic kidney disease, and if you choose your cohorts carefully and you match appropriately, it's perhaps more common in polycystic kidney disease than it is in chronic kidney disease of alternative etiologies. And it occurs early in the disease, so even in patients who have relatively normal renal function with a creatinine clearance of greater than 90 mils per minute, a third of those at a young age will have hypertension. And as you stated, the pathogenesis is thought to rely on activation of the renin-angiotensin system. So there is some basic science data and some human data to support this. In nephrectomy specimens, there is evidence that large cysts compress the renal arterioles, leading to glomerular ischemia and renin release from the juxtaglomerular apparatus. The cyst epithelium itself, which is derived from the renal tubular epithelium, contains all the molecular machinery required to synthesize renin, and there's some evidence that it contributes to systemic renin production and certainly to intrarenal renin production. And then, of course, angiotensin II will cause hypertension through the pathways that we all know very well. And as you stated, it will also drive progression of the renal disease by stimulating cyst proliferation and renal fibrosis. If you look in patients with polycystic kidney disease, there is evidence of plasma volume expansion, elevated plasma renin activity compared to matched controls, and an exaggerated vascular response to ACE inhibition. So for all of these reasons, historically, renin-angiotensin system blockade has been the preferred antihypertensive strategy of choice in polycystic kidney disease, in common with many other causes of chronic kidney disease. But this has never actually been tested in a randomized controlled trial directly. There have been meta-analyses of studies in non-diabetic kidney disease and subgroup analyses in polycystic patients, which do show that ACE inhibitors have a greater effect on proteinuria than alternative agents, but they have no clear effect on disease progression in these studies, although you'll note that the mean baseline creatinine of around 3 mg per deciliter indicates that these studies were carried out in fairly advanced disease. These data weren't available to us at the time that we were making this decision, but last year saw the publication of a large multi-center randomized controlled trial designed to test renin-angiotensin blockade in polycystic patients. So it's a slightly complicated study design. The study actually comprised 2 separate studies, one looking at early disease in patients who had an estimated GFR of greater than 60 mils per minute, and one looking at more advanced disease with an eGFR of between 25 and 60. The studies were designed in this way because the primary outcome was different in each. So in the early disease, total kidney volume and the rate of change in kidney volume was chosen as the primary outcome because that's, for various reasons, a good biomarker of disease progression. Whereas in more advanced disease, a clinical outcome, a composite of time to death, time to end-stage renal failure, and time to 50% decline in GFR was chosen. For all of the reasons that I mentioned on the previous slide, it was deemed unethical to include a group that didn't receive any form of renin-angiotensin blockade, so the comparison was made between double blockade with lisinopril and telmisartan versus lisinopril alone. And the bottom line is that there was no, in either of the studies, there was no additional benefit of dual RAS blockade over lisinopril alone. The early arm here also included randomization to target blood pressure of 130/80 versus 110/75. These are young patients, so that's sporting, they tended to tolerate that. And there was a small benefit in the primary outcome, so kidney enlargement was slower in the intensive control group. But taken together, there is no randomized control trial evidence to support the use of ACE inhibitors in these patients. I'll pass you back to Beam.
So this patient remains hypertensive. He's got stable chronic renal impairment with a creatinine of around 150. His blood pressures, systolic, diastolic, are respectively about 150 to 160 and greater than 100. And just to remind you that these are the current medications here. So again, we have several options as what we could do. So we could add the diuretic, which I'm surprised nobody's suggested yet. We could reintroduce the ramipril for the reasons that we discussed earlier, in addition to the proteinuria. You could use something else, or you could do more investigations. So I've reminded you of all the clinical data at the bottom. What would people like to do?
Okay, we have our nephrology expert, yes. Please.
I feel you're going to give the game away rather quickly.
So the option here that could we use central action like clonidine, but I think somebody with depression and maybe brain injury who try to avoid clonidine. The next drug I can use minoxidil. Minoxidil is direct vasodilation, strong drug. It can reduce.
Sorry, was that
minoxidil?
Monoxidil.
Moxonidine.
Yes.
Okay, sorry. Yes.
Okay. So this
Minoxidil.
Minoxidil.
Yes.
Okay, minoxidil.
So
All right.
this is the option till his situation is stable. So I'll use it for a short time, maybe till his condition completely stable, and then I'll go back again thinking about ACE inhibitor or other. So
Okay.
that's my option in this case.
I'm very interested that you would use clonidine or minoxidil prior to a diuretic, though.
I will not use it because with syndrome, with depression, clonidine with depression and these so like a stroke, like attack, encephalopathy, I'll try to avoid it till he completely recover, and I will not put him again in depression.
But the question was, why not diuretic?
Yes, or the ACE inhibitor. They're cheaper, potentially more effective.
It can.
He has no problem with hair loss.
But still, in somebody with acute kidney injury, with acute kidney injury, I will and with not fluid overload, with acute kidney injury, and he's not overload, I will be trying to avoid diuretic for this, because any patient with severe hypertension, he usually he's volume depleted, and then if we put in diuretic, will be more volume depleted. So that's why I'll try to avoid it. But if he volume stat is good, FEB high, and edematous, definite diuretic would be my choice.
Okay, I will add that we are now some time down the line, so I think his acute kidney injury has resolved, and we are left with stable CKD now. Would be my interpretation of the data. Okay. But thank you.
Microphone 2, and then back 1.
I think you very astutely pointed out early on that there will be, one of the options was no change in therapy.
Yes.
And I guess like any experienced nephrologist or dealing with these patients, this is probably not the AKI that made his creatinine go up to the 2.5. It was a very hypertensive patient who has a rightward shift in the autoregulation curve. He comes in, you drop his blood pressure to nice 130/70. That's exactly the wrong thing to do.
Yes.
And that's why his creatinine went up. It's too fast. And now it is perfect time to go back on some kind of an ACE of your choice that would be.
Fair enough. I would personally agree with you, yes.
Okay, so we have microphone 1, number 1 and number 2, yeah?
Name is Yazbek from the UAE. Would you consider using L-Aspirin in this patient?
So that's a very good question. I think in Scotland, we probably wouldn't, because at the moment it's on a named patient basis, and certainly from a renal point of view, I would argue that whilst it might be a very good anti-hypertensive agent, the data suggesting that it is of benefit in CKD longer term in terms of morbidity and mortality are lacking, which are present for the cheaper and effective alternatives of ACE inhibitors or angiotensin receptor blockers.
Okay. And Jan Stassen, last word.
What about replacing doxazosine and metoprolol by labetalol, which is a combined beta and alpha blocker? You don't have to adjust the dose in function of renal function.
Yep.
And then adding a long-acting low-dose ARB like andesartan or whatever.
Okay, so I think that's a very good point, and I will say that is an option, although I would say that labetalol is not a drug used commonly by the renal community. But exactly, so if you say to a nephrologist in beta blocker, you would get two answers. You would get metoprolol because of its pharmacokinetics and dynamics, or you'd get probably bisoprolol because of the heart.
Okay, so one more comment, yes?
Yeah. Can I, because in your ambulatory blood pressure monitoring, it clearly shows that nighttime blood pressure is even higher, especially systolic, than daytime blood pressure. It means that the patient probably had volume expansion, and you use doxazosine at this dosage. You know, doxazosine may have a little problem of volume expansion or retention. So I would suggest that you reintroduce ramipril or other ACE inhibitors with a little bit lower dosage compared with the previous higher 10 milligram ramipril. And the other thing is, it's probably you should also provide a diuretic in the daytime than to have a volume decrease, then you probably would expect a better blood pressure control in the evening and overnight. Thank you.
Thank you. Yes, no, that's very helpful. That is incredibly helpful.
Okay, so what really happened?
Despite our rather cavalier attitude towards ACE inhibitors early on in his course, we seem to have been quite cautious at this point and avoided reintroducing one, but did start him on benzoflumethiazide and moxonidine, and his blood pressure didn't really budge. So at this point, we're now 3 months out on all of those agents and still significantly hypertensive. I should perhaps at this...
Lots of unhappiness in the audience. We'll hear in a minute why, right? Okay.
I should probably at this point out that actually the patient himself played quite an active role in choosing his therapy. He was a doctor, he was back at work now, he had a busy clinical job, and he had previously been reasonably, understandably very resistant to diuretic therapy, partly through a desire to avoid postural symptoms and partly because he wasn't in a job that would allow him to nip to the toilet regularly, and that also influenced the timing of his doses. So in the interest of time, same option again. He's now on all of those agents. Blood pressure is still 170/100 on home readings. What should we do at this point?
Okay, there is a comment.
I'm sorry I came late, but the best doctor is the last doctor. I heard all the other colleagues here, and I realized that this person has a very high blood pressure, could not be explained alone by polycystic kidney disease, and also has an Rhian effect because you tried that twice and the creatinine went up and down, and when you gave diuretic, the pressure was worse. So try to see if there is another secondary cause for hypertension, since I have seen primary hyperaldosteronism with renovascular hypertension together. So this guy could have renal artery stenosis on top of polycystic kidney disease. So you need to investigate for that.
Mm-hmm. So you're suggesting that he's very, very unlucky.
Yeah. So I think there is a good suggestion. Something doesn't quite add up. This blood pressure should have gone down. If you're not succeeding in a young patient, is there another diagnosis? So I think that's a very good suggestion. Diagnostic tests again. There is another comment.
I'll go again back to ABC. Now, this patient have 4 drugs. He will not respond, so I'll look for, is it resistant hypertension? Is it complying with the patient ambulatory blood pressure, just to be sure that really we are facing that high blood pressure, not office hypertension. So I'll go back again to all this step, because somebody who will not respond for medication, I think, and also I have to review if he taken any other drug from any other physician, just to be sure that really we are facing uncontrolled hypertension.
I'm just going to comment on the compliance issue. So whilst we cannot be 100% sure that he was compliant, he was very engaged in his management. He was at home, he kept daily, twice daily, 3 times daily blood pressure records on his iPhone with an app that, he would text us using e-medicine and tell us that his drop was this or his drop was lacking and what symptoms he's got. So I would suspect that he was compliant, although I couldn't guarantee that. So I think the other investigations, as you suggest, as Anna suggests, don't fit. So we did move on to further investigation.
Could we have one more comment? We're running towards the end of our time. We're still comfortable, but one quick comment, quick answer, and proceed.
I'll keep it brief. The option of reintroducing ramipril seems appealing to me, in a lower dose perhaps. So you previously showed that it is very effective, perhaps a bit too effective in controlling this blood pressure. So this suggests that, as you explained, the mechanism is renin mediated. Perhaps because of compression of efferent arterioles, you did a bit too great a job, and you should just reintroduce ramipril at a lower dose. And you've given then additional efferent protection. So in the long run, this will hugely benefit, I think, his already worse kidney function.
Okay.
Thank you. We considered all of those, but what happened next was that he got a magnetic resonance angiogram, and I will just flick through the images.
Yeah. Ouch. Mm-hmm.
So I'm sure you spotted the stenosis near the origin of the left renal artery. And if you've got good eyesight, you might see that there's the suggestion of a small stenosis at the origin of the right renal artery as well.
Yeah.
So he was incredibly unlucky.
Yeah.
And this is the formal dye angiogram, which confirmed the presence of a 9mm stenosis in the proximal portion of the left renal artery with pre- and post-stenotic dilatation. Actually, the right renal artery looked fine, it looked normal on the dye angiogram. So the differential diagnosis of a lesion like that includes atherosclerosis, fibromuscular dysplasia, large vessel vasculitis, and there is, of course, a group of more unusual conditions, very rare stuff like segmental arterial medialysis. Bean, do you want to say this?
Okay. So hopefully we're not running too far behind. We've given you the differential diagnosis of this renal artery stenosis. So you've got atherosclerotic renal artery stenosis, fibromuscular dysplasia, a vasculitis affecting medium and large vessels, or rare conditions such as segmental mediolysis. So what do the audience think about the diagnosis here? And the importance, I think, of knowing the diagnosis is deciding then its natural history and potential intervention, or management, I should say.
Okay, any takers? What about our expert nephrologist? Yes, we've got another nephrologist.
I did not know his history. I did not know the cholesterol, hypertension, cardiovascular.
Okay. So his cholesterol is normal.
He's 30 years old?
Yes, he's about 30 years old.
His arteries looks okay. I don't think that he has atherosclerosis. Could he have something else?
Okay, so that is all true. He has no significant cardiovascular risk factors. He's a non-smoker, fit, no evidence of atherosclerosis elsewhere in his vessels.
From the shape of the vessel,
yes.
Although he is a man, it must be fibromuscular dysplasia.
Even though he's a man, yes.
Even though he is a man, it looks like fibromuscular dysplasia.
Is there anything else on the imaging that seems odd to anyone? Okay, I'm going to hand you over to Rob again.
Right.
Our radiologists had commented, in addition to the findings that I pointed out, that they felt his iliac arteries were unusually tortuous for a gentleman of his age. Yeah. This perhaps doesn't come across actually from a static image like this. Yeah, we felt for all of the reasons that you mentioned, this was fibromuscular dysplasia. I won't labour the point here because we've had some excellent sessions on FMD today and yesterday. But fibromuscular dysplasia is reasonably prevalent, certainly, or at least in a clinically silent form. So if you look in potential kidney donors or in the CORAL cohort, which of course was a study into atherosclerotic renal disease, there's about a 4% prevalence of renal artery fibromuscular dysplasia in the general population, but most of that is clinically silent. It's far more common in women. It can present at any age, and it's associated with a variety of other vascular malformations, including tortuosity of the medium and large arteries. Historically, it was treated surgically and therefore classified histologically in contemporary practice because it's often treated and diagnosed radiologically. It's classified along those grounds. The more common variant of the disease is multifocal and gives a string of beads appearance on angiography, which arises as a result of alternating regions of stenosis and interstenotic dilatation. And that tends to occur in the distal 2/3 of the renal artery and is almost exclusively found in women. In 20% of patients, there is a unifocal variant of the disease which can affect any segment of the renal artery, tends to present younger, around 30 years of age, and although it's still more common in women, the ratio between the sexes approaches unity, so this fits with our patient. Final part of the discussion.
So we have a chap who is in his
There is a comment.
One clue in during investigation, this patient that he have renal artery stenosis, that when we put an ACE inhibitor, the creatinine was raised.
Yes.
So this is one of the clue that if it happened, we should always rule out renal artery stenosis.
Absolutely. I mean, I think you're absolutely right, and I agree. I think the problem was the timing of the ACE inhibitor introduction, given that we thought we were still in a period of acute kidney injury, whereby reducing, as one of the other gentlemen said, reducing perfusion pressure may have accelerated the rise in creatinine. Yes, although this was unilateral. Yes, but what is important here is that this gentleman has underlying significant chronic kidney disease. So I suspect that would make it more apparent in the absence of bilateral renal artery stenosis. So we have a gentleman here. He's got polycystic kidney disease with chronic kidney disease. His blood pressure is uncontrolled. He's currently not receiving any renin-angiotensin system blockade. We've diagnosed him with angiographic renal artery stenosis, which we think, in terms of probability, is non-atherosclerotic, and so we think it is fibromuscular dysplasia, albeit he is now the least common of every sort of category of disease. So the question then is, what do we do? I mean, we actually have a blood pressure of about 160/100, which actually within the renal community, some people would accept. We have patients with blood pressures much higher than this. So the option there is to do nothing. We also have medical measures. So would you use enhanced pharmacological antihypertensive medications? Would you add in secondary prevention? Or would you intervene? And I think to answer that, you probably need to decide what are you trying to achieve here?
So you are at the hypertension meeting. Doing nothing with blood pressure 160 systolic is not an option according to our guidelines. Please.
We know the results of angioplasty are not 100% corrective for the blood pressure, but I think in this particular person we should consider it. My concern was on the arteriogram that you did. I was just wondering, with such a good picture on MRI angiography, and with the risk of the dye on the kidney function, would we have avoided that and moved on only to the point where we need to do angioplasty?
So I think the impact is a very good point. I think the impact of contrast in this GFR is probably more worrisome to non-nephrologists. So from my point of view, his creatinine, albeit impaired, his renal function was actually pretty good. His GFR was around 80 mils per minute. And I think in that context, provided one is adequately hydrated, there is no ACE inhibitor on board, I wouldn't have a major issue with contrast. And the radiologist in particular was keen, because it was such an unusual MRA, he was keen to do formal angiography.
Okay, so one more comment.
In general, the treatment of fibromuscular dysplasia is angioplasty. This is the treatment. And I think in somebody who is many medication and for sake of future management and he have serious attack of encephalopathy with high blood pressure, I'll go for angioplasty for this patient. I inform him about the complication of contrast and side effect, but I think that should be go for angioplasty. Okay. I hope I'm right.
Could you just stop for a minute, and could we have hands up of everybody in the room who is a clinician who would like to do angioplasty in this patient? See?
Could I ask you, all of you, what you want to do angioplasty, what is your aim here? Is your given the meeting we're at, is your aim blood pressure control?
Both.
Blood pressure and?
Preservation of renal function.
Preservation of renal function. Okay. Could I ask the opposite? Would anybody not do this? I appreciate you might have to be brave given the number of hands that have just been shown.
Gary's all the way from
and actually I'm going to preface this by saying...
shorten the conversation. If this was atherosclerotic, I'd be saying medical therapy, but I think because it's fibromuscular hyperplasia, it's different. The second thing is, yes, blood pressure control would be highly desirable, but also the ability to use ACE inhibitors or ARBs without any constraint would be a useful outcome in itself.
So another comment.
Just to follow up on this comment, so the CORAL and other trials should not be coloring our decision here, because this is different disease. And what was the gradient across the lesion?
Oh, so I don't know.
We didn't measure that. I know there's a
looks significant from the dilatation post stenosis.
Yes.
I think your answers are covered in minutes, actually.
Yeah.
Okay, so we have about 6 minutes left. So could we hear the rest of the story, please? Right.
So as I'm sure you know, there is a school of thought of best practice in terms of medical management in fibromuscular dysplasia, but due to the rarity of the disease, there aren't any adequately powered randomized controlled trials to guide this. I think the same could actually be said of angioplasty, although there's no randomized controlled trial of the on the scale of Coral or Astral. There is still a lot of good observational data, most of it retrospective. There was a systematic review and meta-analysis in 2010 reviewing the literature to date, which suggests that hypertension cure rates are reasonably good, although follow-up's short, restenosis rates are not inconsiderable. But importantly, and this factored into our decision and clearly into your decision to intervene, that you get better outcomes in younger patients in focal disease.
Yeah. Could I just say that Astral was atherosclerotic, old people, a very different trial. I don't think we should
absolutely.
You know, this is a different discussion.
We totally concur. And our aim of treatment was to manage to treat blood pressure, but also I agree with the point made that it then allows you to introduce renin-angiotensin blockade, which will be beneficial for his chronic kidney disease. So he went on to have an angioplasty. The initial attempt was made via the femoral route, which was unsuccessful, providing further evidence of this tortuosity. The second attempt, made via a transbrachial route, was successful, and he had a diuresis of 21 litres in the first 24 hours, which I think confirms that it was a hemodynamically significant lesion. So these are the pictures. That's the catheter coming down from above, and again the angiogram beforehand showing the post-stenotic dilatation. That's the guide wire being passed across the lesion, and after balloon inflation, that's the post-procedure angiogram showing a good radiographic result. We didn't deploy a stent. And this is his outcome over the 2 or 3 years since the procedure. So you can see his presentation clearly was an acute kidney injury, and this is his sort of baseline chronic kidney disease. And his renal function hasn't really changed since the procedure, but you wouldn't expect that. And all of the available data, there isn't a lot of it, does suggest that you make no difference to renal outcomes, but you do treat hypertension. And his blood pressure did improve. So you'll recall that prior to the procedure, he was on 5 agents, including a diuretic, with suboptimal blood pressure control. I think immediately beforehand it was 170/100. And relatively soon after the procedure, his blood pressure was 110/50 on amlodipine, ramipril, and candesartan.
Okay, could I quickly, because we're running out of time, why do you combine sartan and ACE inhibitor? What's the rationale?
So you have to remember when this case occurred. So it was, well, actually, Bean, do you want to field that?
Oh,
so I think
explain yourself
absolutely.
To this audience.
So I'm not in any way defending On Target. What I would like to say is that I think On Target was very useful in the cohort of patients it studied, and it remains unclear in those patients who are non-diabetic with no cardiovascular risk factors, who have residual proteinuria, of whom there are many, for example, the young patients with IgA nephropathy, membranous nephropathy that we see, whether dual blockade does impact long-term renal function and cardiovascular morbidity and mortality. In this patient, we didn't at the time have the benefit of HALT PKD, which compared the single ACE inhibitor versus the dual blockade. And so the rationale for combining the two was maximal renin-angiotensin system blockade, because as you know, you get the ACE escape and the angiotensin II reactivation. And this system is known to stimulate cyst growth within the PKD cohort, and that was the rationale for it there.
Okay. I think, do you have any more slides, or is that it?
We're just going to tell you pretty much.
I think this has been a fantastic case. Thank you very much for presenting it. Give us this summary. I think we want to hear your summary, and then one comment how we're going to continue, because we want fantastic 2 papers out of these 2 cases. So give us a summary, and then I'll summarize.
So I'll give you our summary. So we presented a case of accelerated hypertension in a young man due to renal artery fibromuscular dysplasia and polycystic kidney disease. His treatment comprised percutaneous angioplasty and subsequent renin-angiotensin system blockade. We have discussed the treatment of hypertension in chronic kidney disease, particularly polycystic, and focused in on the role played by ACE inhibitors and angiotensin receptor blockers.
Okay,
and could we thank you all for the discussion, which we found very helpful, and we also would like to thank our patient, who was very kind in giving his consent for us to present this, Neil Masson, who was the radiologist involved, and Albert Ong, who offered an expert opinion on his polycystic kidney disease.
Great, thank you very much. So all the authors will contribute the draft manuscripts to hypertension. Denise Kyo is in a AHA booth here, and you can talk to her how she would like it done. All the discussants, particularly those who made major contributions, please speak to Denise, give her your emails so you can contribute, because we want to truly have this discussion for others to read and see. And we also would like suggestions for cases for next year. We hope to do something similar in Paris or in another location in about 1 year time. So if you can give Denise in AHA booth ideas of your own cases or colleagues in your teams who would be ideal presenters. And could I thank all 4 presenters for fantastic jobs. Thank you very much. Well done, gentlemen. Thank you. Very interesting.